All right, thank you, Dr. Belli. Everybody doing well? Yes? Awesome. More great information and more on the way. Our next speaker, Dr. Evan Mladenoff, usually needs no introduction, but he's let his hair grow out, so might have not recognized that he's here. So looking somewhere between Einstein and Moses, our own Sun Tzu of chiropractic, 2021 winner of the George Goodhart Award from Overland Park, Kansas. When I was a student, I remember reading his papers and the collected papers and amazed at what he was doing and so excited to meet him. Maybe he'll share with you a picture of his amazing handlebar mustache he used to sport. But now the Mladenoffs are spread around the country with Diana in Phoenix and Chip back home probably watching us right now. Hey, Chip. And Sandy, the CEO at the home office. So 44 years later, still knocking it out and going to bring some next level information for us. Please help me welcome up Evan Mladenoff, Dr. Mladenoff.
Okay, am I live? Excellent. There's a couple things I'd like to talk about. And the first is, Angela was worried about me because I only have 22 slides. And so in the past, you've probably seen I usually have about 400 slides that I go through very quickly. But then I said, Angela, we have a problem. And I said, in order for the docs to get CE credits, there's supposed to be a quiz at the end of each class. So here's the deal. You're going to take the quiz, so you don't have to do any quizzes for the rest of the weekend. So take out a piece of paper, and if you write your answer down, so here is the question for the quiz and for CE credits. So some of you are familiar that I'm of Eastern European background. Dobar den, ja se prezivam Ivan. And I basically said, good afternoon, my name's Evan. Here's the question. What's your answer? Does my hair look like Lao Tzu? Does it look like Moses? Does it look like Einstein? Or does it look like Rasputin? For CE credits, write down your answer and give them to my wife, please. All right, the second thing is I'd like to thank Michael Leibowitz for honoring our dear friend and one of the founders of our organization, Dr. Otis Thomas. And Dr. Otis always said, don't let your presentation get in the way of what you want to say. And Michael did that today. I thought, that's a really good idea, Michael. I think I'm going to do that. Here's what I'd like to say. And that is, this weekend on display, we have what I would call generational applied kinesiologists, starting with George Goodhart. His father was a chiropractor. One of my favorite mentors, Leroy Perry Jr., his father was a chiropractor. Dave Walther. I won a lot of money on this bet. I bet my wife that Dave Walther's father was a chiropractor. And she said, no, he's not. I won a bronze Remington sculpture that's in my basement. If you've been to my house, you've seen the sculpture. If you haven't been, you need to come and see the sculpture. But I won that on the bet. But here's what I didn't know. Dave Walther's wife was also a chiropractor. That's pretty impressive. Let's fast forward a little bit. We need to honor Dr. Leibowitz and his son, Noah. I believe it's her first meeting here. Hannah Force and her dad, Mark. And then we have Dr. Tom Heath, who has two sons that are in chiropractic college right now. That's pretty cool. And I have the great fortune that my two kids followed what I'm doing. And we never said you should be chiropractors. They just decided on their own they want to be that. I want to speak to all the kids, the second generation chiropractic kids. I don't think this, but everybody tells me I'm the old guy now. And I don't feel like I'm the old guy. Somebody has to carry the torch. There's two ways you can carry the torch. The first is wait till we drop it, which I don't think any of us are willing to give it up yet, or come and take it from us. And I'm urging the next generation to come and take it from us. And if you have kids, we have our next AK doctor is only 6 months old. Is she back in the room? If you hear her crying, it's her first AK meeting. She's 6 months young. Generational AKers is something to be proud about, and we've already started that. That's way cool. Come and take it, because we're not going to give it up willingly. And so the next thing I want to say is, I was honored last year given the George Award, and I really don't think I'm a special guy. I just like working hard. And to me, the word is not important. What is important is that I'm mentioned in the same sentence as John Bandy and Michael Allen, who also received the reward at that time. And that's beyond belief, to be acknowledged with those two pioneers in our profession. So I want to thank John, and I want to thank Michael, and I want to thank the committee who voted for me. But to me, that is spectacular that I even get mentioned in the same breath as those two fabulous doctors. That's all I wanted to say. I'm done. Okay, let's go on with my talk. Before I start, I'm going to give you a case history, because to me, a couple of people touched on it, and it's simply that is, okay, how do you think AK? And that's, as a teacher, to me, that's the most important thing is, how do I help the students think in AK? Here's the case history before we go through my topic. You have a 12-year-old girl who had braces put on. 2 weeks later, she goes deaf in one ear. 2 months later, she shows up in our office because a family member said, nobody's helping you. Maybe these doctors can help. Just take a couple of minutes, write down something real fast. What would you do for that patient? Where do you start thinking about that patient? I put braces put on, 2 weeks later goes deaf in one ear, and we see her about 2 to 3 months after that. Where would you start? Keep that in the back of your mind as we go through everything. All right. Now, last year I presented the vestibular branch of the cochlear, the vestibular nuclei of cranial nerve. So this year I'm going to do the cochlear branch, and if we have time at the end, we should be able to workshop both of them. Okay, there we go. Here's the George Award. Again, thank you very much for including my name in the same breath as John Bandy and Michael Allen. That's like overwhelming. So I want to, if I get tongue-tied, there's a reserved seat up here for our dear friend Wally Schmidt. And he was my fact checker. Because when I was up here, I knew how I was doing because I could just see Wally over there and he'd nod, or he'd kind of like, he wouldn't do anything, he'd go, or he'd start writing down like crazy. I knew how I was doing by watching Wally. And I feel a little naked this year. I need a new fact checker. The second generation AKers, I'm going to charge you guys with it, but that means you have to sit in the front row because I can't see you back there except for my daughter, Diana. I need a fact checker, so Wally's not here. So I'm going to do this. I promised myself I was going to do this every time I spoke, and that is, here's one of the ways I'm going to honor Wally, and that is, without a few exceptions, all activities of the CNS, receiving, processing, and integrating information ultimately finds its expression in a muscle. The ventral horn theory and manual muscle testing. Everything ends up at the ventral horn, and the ventral horn communicates with the alpha-1 motor neuron. That's our tool. That's what we use. And some of you know this as the final common pathway by Sherrington. And whatever information comes into the ventral horn can be displayed on the muscle. That is limited by your imagination. That's how you think AK. What information, what are you doing to the patient? What are you having the patient do that is driving information into the ventral horn that then you can measure its effect on a muscle? Does this make sense? And I'm going to say that every time I start the lecture because I learned that from Wally. And that's one of the ways I'm going to honor Wally. That's our tool, the final common pathway, and we can measure that. Back in 2018, we were fortunate enough, after several head traumas in our family, to get a registered trademark called concussionology, what happens with head trauma. And we've developed this concept over the years, and that is in any head injury, there are actually 5 things that happen. And so here's our matrix of the injury, 5 things that happen in every injury. Now the question is, which one will be dominant, which one is priority? If you've seen one concussion, you've seen one concussion. They can be the same injury, the same mechanics, the same equipment, they're different. And it's like you find the patient where you find the patient. The concussion finds the patient where they find the patient. Here's what we're going to talk about today. We're going to talk about a vestibular injury, and we're going to talk about, here's all the parts of the vestibular matrix. We're going to just focus on that one right there, just the cochlear nuclei of the central nervous system. If we don't have time, I've created a video that we're going to have online, and I've also created some extra downloaded notes. So if you text ICAK 2022 to that phone number, it'll ask you for your email, and then we'll send you stuff periodically. I've also included that you'll get the video of how to examine the vestibular nuclei that I did last year if we don't get time to demonstrate it here. You'll get 2 videos and a bunch of extra downloads of how you can examine and treat the patient that are a little more extensive than we had room for in the notes. The cochlear nerve, cranial nerve 8, we're going to go through a little bit of anatomy here. First thing is, what is a traditional neurological exam? What do they examine to figure out the cochlear nerve? Well, there's loss of hearing, tinnitus, distortion of sounds. There can be audiometry. Dave Walther, I think, had one of these in his clinic. There can be speech audiometry. There can be Rene's test, and there can be Weber's test. One of the things that I learned from Dr. Schmidt was when you do, I'm going to get this mixed up. When you put the tuning fork on top of the head, which one is that? That's Weber. He said do Weber's test, but do it in 3 positions on the head down the sagittal suture. If they have Wormian bones, it may affect it, but if they've had a concussion, you will not believe, you put it in the front area, it radiates to the left. You put it in the middle area, it doesn't radiate anywhere. You put it in the posterior area, and it radiates to the right-hand side. You'll have all kinds of bizarre patterns happening when there's head trauma. This is a really great test that you can do, easy to do, that will tell you 2 things. You may be able to predict the area of injury where the first contact was, and then the contra coup injury within the brain sloshing around inside the cranium. But you also may then be able to predict where there's a neuroinflammatory response in the brain itself. That's pretty cool, just with a simple Weber's test. I learned that from Dr. Schmidt. Let's take a quick look at the auditory branch. Here's a close-up of that and the number of structures. If we have sound coming in from one ear, here's the pathway that's going to happen. First, we get stimulation through cranial nerve 8, and then it activates the cochlear nucleus. Then, from here, the pathway goes up to the superior olivary complex. Then it also goes down to the facial nerve nucleus. I think all this is in one slide in your notes. Then we also get the cochlear nucleus affecting cranial nerve 7, the facial nerve. And here's the biggie right there. We will get the decussation from cranial nerve 8 to the opposite olivary complex. And then that goes down to the cochlear nucleus and then to the opposite tympanic membrane. What does this mean in English? You hear a sound on one side, you have stereophonic sound instantly in your head. So when it comes to examination, we need to think about not just the side you're testing, but the opposite side as well. Here we have another decussation between the superior olivary nuclei. We have 2 different decussations from sound coming in just one side. And then we have from the cochlear nucleus going down the tectospinal tract. This is from Seba Netter collection. And we have sound coming in. I'm going to just step down here so I can see this a little bit better. We have sound coming in, and you see a little more detail. We come through the cochlear nucleus, then we get a decussation or a splitting at the pons. Okay, we come up to the superior olivary complex, then we get a decussation again. The bottom line is it comes to both ears simultaneously. Sound in one ear has 2 different decussations to end up where we have stereophonic sound. Here is something that I found out, and it has to deal with that case history. The decussation at the superior olivary nucleus in the pons. There's a decussation at the dorsal acoustic striata in the pons. Then we get stereophonic sound simultaneously at the auditory cortex and the contralateral auditory cortex. The inferior colliculus, here's the home run, here's what you need to circle in your notes, controls muscles of the head and neck to locate where the sound is coming from. If we could produce a loud sound over there, what would you do? You'd turn over there to see where the sound's coming from. That's triggered by the volume of the sound and location of the sound. Then the next thing that happens is the auditory reflex will affect via the tectospinal reflex and the reticular formation. It'll control movement of the head in the upper cervical muscles. We have lower cervical muscles and upper cervical muscles being affected. And here's the home run that I've circled in green. The olivocochlear nucleus is a cholinergic nerve. And you just heard Dr. Belli talk about the vagus being a cholinergic nerve. Some of the problems we found with cochlear nerve problems related to head trauma, it has been a cholinergic nerve problem, and you can bet that the vagus nerve is also involved in those patients also. So one of the things that we've developed, and should be available kind of mid-October, we're hoping, is a nutritional product that is helping develop acetyl-CoA factors to help upregulate vagus nerve function and, in this case, cochlear nerve function. Now here's a lot more detailed diagram. This is from the Netter SIBA collection. If you have that or have access to that, I have one of the original green books from the SIBA collection back when I was in chiropractic college 3 weeks ago. And then I also have a CD-ROM of the entire collection. Of course, now it's available online and multiple things, multiple different ways to get it. How many of you have the access to the anatomy program, Complete Anatomy? The students probably do. That is a great anatomy software program. I don't like it for this kind of stuff because it doesn't allow you to isolate all the different pathways. There's too many things that are changeable. I'm sure they're going to figure it out someday because they've figured out other things as they've gone along with this software program. But that's why I still like the old SIBA anatomy collection stuff for pathways like this. Here's the deal on this. You can see a lot more details at the ventrocochlear nucleus and then at the areas of decussation in the two areas, and then also ending up in the cochlear part of the cortex. The tectospinal tract. The tectospinal tract starts at the superior colliculus, ends at the alpha and gamma motor neurons. Like, whoa, take a deep breath right there. The superior colliculus ends at an alpha and gamma motor neuron. That means we can examine that thing. We have access to that instantaneously. It crosses the dorsal segmental decussation. It inputs from visual and auditory. We have not added in any of the auditory things that could be added on top of this. If we have time, we'll add in some of the auditory things, but they're not in the slide presentation. And it influences extensor muscles of the cervical and thoracic spine, and it can be reflected as dysfunction in the motor system. Pretty cool when you know the neuroanatomy, isn't it? It's like, if I could go back to chiropractic college, I'd spend all the time in the neuroanatomy lab. And then, well, probably neurochemistry too. Now, how can we evaluate this pathway? Here's the home run is very simple to execute. We're going to start, IIM stands for an independent indicator muscle. And we can use two different muscles, the upper trapezius because it's related to the eye and the ear, or we could use the supraspinatus because it's related to the brain. Now, I'm going to suggest you use the supraspinatus. When you check the upper trapezius, you're going to have a timing and a hand issue if you're using a tuning fork. You got to hit the tuning fork, put it down, then go and test it. You're going to get a little hand-tied, if you will, trying to execute the testing parameter. The supraspinatus will be a much better way to do this. So we're going to use two different tuning forks. Now, when I had this first examined on me after my head trauma, is Bill Lerner here? Dr. Bill Lerner? I don't think he's here at this. This was about 3 months after my head trauma. I was not having any hearing problems, but I was having horrendous balance problems. And Bill was at a seminar we were hosting that Dr. Belli was teaching advanced neurology, and Bill says, let me check you. He says, come here. And when he checked me, he just literally snapped his fingers. Now I'm going to do it in front of the microphone so you'll hear how much sound there wasn't. And he just did this. That's it. And the procedure that we're going to show you, he did some of this. I've expanded on it when we do the positions of the tuning fork, but that's all it took. And I had improper inhibition. Bill says to me, he says, do you have any hearing problems? And I said, No, I don't have any problems. I have balance problems. I said, but you better ask my wife. I think she'd admit I have hearing problems. But it had nothing to do with the accident. I had that long before, and it wasn't worse, apparently. At least the complaints about me not hearing things has not gone up anyway, but it hasn't gone down either. That's all Bill did, was just a little, like you snap your fingers, but your fingers are too dry and nothing happens. That's all the noise he made to test me. Fast forward with the patients we've seen with head trauma, I didn't find that in these patients, and I said, we need to somehow stimulate sound a little more. I picked two. I picked the C128 tuning fork. That's a large tuning fork, okay? And then I picked C512, which is 1 octave higher. Here's the, right, there's the 128, and then here is the 512. I just picked those two. I have a whole set of tuning forks with every scale in between, a full C major scale, and then I have solfeggio tuning forks, if you know. I have not tested all those. Those two seem to be sufficient if the problem is going to be there. But I start with just doing the little stimulation like that. We're going to do it both ways. We're going to pick one. We start with the C128, and then what you're going to do is you're going to test on one side, but you're going to, and then test your supraspinatus. You're going to test the right ear, test the right supraspinatus. And then what you're going to do is you're going to put the tuning fork in 5, 6 different positions on the head. I forgot the bottom one, and that just like do it under the chin. So I'm going to just have Jim stand up. I'll show you this real quick here. Let's go. Better for the camera over here. If you just stand up, come on up close, and just face everybody. We have to have stage presence. So all I would do is I'd hit the tuning fork, hold it here, and then I would test supraspinatus. But then you got to keep the sound going, and then I'm going to go to the opposite side, then over top of the head, behind the head, in front of glabella, and then you should do under the chin as well. Remember, we get the decussation to the opposite side, we get stereophonic sound, so you should test the sound in all positions around the head. And that's a real simple procedure. Do it with C128, and then do it with a 512. And you'll be surprised how many times you'll only find one of the positions it'll be off. And only one of the tuning forks will be off. And again, if you've seen one concussion, you've seen one concussion. It's all over the place. We're just looking for an abnormal auditory nerve response. Make sense? All right, now how are we going to fix this? Well, here is thinking AK in my terms and in my prism. And that is, AK is notorious and sophisticated and brilliant in a mechanical concept called system redundancy. I'm on the 14th floor of the hotel. Well, if there's a fire, there's more than one way to get out of my room and get down to the lobby level and get out of safety. That's system redundancy. You can use the elevator, you can use the stairs at this end, stairs at that end. You could go outside. If somebody's there with a ladder, they'll come and get you somehow, right? System redundancy. That's what AK has. And that's the confusing part. If you don't understand that concept, well, wait a minute, the guy I learned how to test cochlear nerve said, this is how you do it. And, well, here's how you fix it. Well, there's lots of different ways to do the same thing, right? System redundancy. So don't when you're thinking AK, I think system redundancy. Okay, there's more than one way to find this out. What's going to be the quickest way? And if that doesn't work, then what should I do? Does this make sense? That's how I'm going to think. Now, how are we going to find out what's going to be the cause of this and the solution? We need to pre-test neck rotators. This is the second way we're going to do it. The first way is you're just checking the sound and the supraspinatus muscle. The second way you're going to test this is you're going to pre-test for neck and head rotators. There's 2 ways you can do this. You can try to do a sternocleidomastoid and then do an upper trapezius and then do a scalene, but that's specificity. And so one of the things that we started finding out was if we just do a generic head rotation, without testing just the SCM, without trying to isolate a muscle. Just rotate the head. Here you have to be careful. I'm going to show you a side profile. You want to make sure you're not just pushing on the TMJ and doing this. You have to turn the whole head and have the patient resist that motion. You're going to have them do that, but now you have to see, okay, do I have a good indicator? All the rules still apply. You still have to do autogenic inhibition, so is the muscle facilitating and inhibiting properly? So you're going to do that for head and neck rotators, and then you can also check flexors and extensors. So you need to pre-test those before you do anything else. Then the next thing you're going to do is the head is going to move to the side of the sound. I put the tuning fork on the right ear. Where's my head going? It's going over here. What muscles should be inhibited? These ones over here. You can't turn it this way if these guys are working. A normal response is inhibition of the opposite neck rotators. If I put the sound here, where's my head going to go? It's going to go this way. I should have inhibition of what? The extensors. You just have to figure out, okay, where do you want to put the sound and how do you want to test this? Again, we're going to do this two ways with two different tuning forks. And then if we test our opposite muscles to where the sound is coming from and we do not get inhibition, then that's a positive result. Let's back up, we'll summarize. First way is test the tuning fork with the ipsilateral supraspinatus, put the tuning fork in 6 different positions around the head with a test of the supraspinatus each time. Check that on both sides. Then do it with the other tuning fork. The second way you test this auditory nerve is you're going to check for rotation or movement to locate the sound. That's where you need a loud enough tuning fork. That's why usually the C128 is better. There's a bigger sound. Now, if you want to create a bigger sound by clapping your hands, what does a baby do when you clap your hands? Turns the head to that side, right? So that's what we're talking about. However you want to execute that. I don't have tuning forks loud enough, what should I do? Well, thump your hand on a book or thump your hand on the table to make a loud sound close to the side you want to test. And then you're going to test for the opposite muscles to where the sound is coming from for inhibition. If there's abnormal function, there will be abnormal inhibition facilitation cycles. Does this make sense? Is it just straight, regular? Okay, trivia question. Do we call this functional AK or functional neurology? Or both? I would think we should call it the Mladenov technique, and you should pay me tens of thousands of dollars to come and learn how to do this properly. How about we do that? Would that be all right? That includes you people online, too. All right. Now we can use our AK toolbox to figure out, okay, what do we have to do to normalize cochlear nerve function? We can use a number of different tools. We can use therapy localization. We can use challenge. We can use the gustatory reflex. That's one of my favorite words, the gustatory reflex. We can check acetyl-CoA factors. This is one of the patterns that led us to developing this nutritional product. Not only the vagus nerve, but this particular nerve. Remember, it's acetyl-CoA dependent. Cochlear nerve, acetyl-CoA dependent. In the demonstration, the video demonstration, I've got this online that you'll get a copy of. To view, we have the patient just inhale through their nose the acetyl-CoA product. So we just open the vial, have them sniff the powder, retest the tuning fork positions, however we found the inhibition pattern there. And then we would support the person with 1 cap 3 times a day of the acetyl-CoA. Now, if you're using something else to nutritionally manage the acetylcholine pathway, this is the place you could do it. The things that Dr. Belli talked about, all the detailed cofactors of upregulating acetylcholine, you could use those. We now have a problem. There's only 2 chemical pathways for upregulation of acetylcholine. There are 6 competitive inhibitory pathways for acetylcholine to be made. It could be one of those 6 competitive pathways that are suppressing acetylcholine function. So you can give the patient acetylcholine A factors. And one of the reasons why we are developing this product is patients who take straight acetylcholine from different companies, that's like giving them speed. It's like some people say, Doc, I got to take that. It's like it's better than caffeine. And he knows what I'm talking about. It really is. It really is. Are they really correcting the problem, or are they just they're overstimulating a pathway. Again, the nutritional component may not work because there are 6 inhibitory pathways for the upregulation of acetyl-CoA. I've not figured out how to deal with those yet, other than they're there. Our next possibility, remember, the upper trapezius muscle is related to the eye and the ear, but it's also related to the kidney meridian. It possibly could be a kidney meridian. Back to the case history I gave you to start off with, there was no head trauma involved, like a concussion. We need to determine, is the kidney meridian involved? Simply what we're going to do is okay, now, who knows what a mu point is? Okay. Those of you that don't know what a mu point is, you have to take my 50-hour AK for acupuncture for AK course that we're putting together that I should have by the end of the year. So it's going to be really cool. But a mu point is the alarm point. It's the alarm point. Alarm point take up too many spaces on the slide and it wouldn't be able to fit everything in. I used mu point. So you're going to therapy localize the kidney mu point on the side you put the tuning fork on. And then retest how you got there. Does that make sense? Now you need to figure out, how do I balance the kidney meridian? And that's a whole nother story. It could be simply, you need to tonify. By the way, as our population ages, what are the 2 of the things that are affected most by? They're wearing hearing aids and their eyes. They either get cataracts or they need readers. Fortunately, I don't need readers yet. But that's eye and ear, that's kidney meridian stuff. And traditional Chinese medicine says, okay, the reason why those things happen in anybody, but especially in our adult population, they have kidney problems, kidney energy problems. Easy fix with AK tools. You're going to do the cochlear nerve testing, therapy localize the alarm point. If that causes the normal inhibition facilitation cycles of our muscles, now you have to do Wu-Jing kinesiology, which is figure out how to balance and repair the kidney meridian. Next, we could go to K27. Why could we go to K27? Well, there's several reasons why. The first is it's called Sheng Fu, if I'm not mistaken, which means the house of the associated points, which means you're checking the entire thoracic and lumbar spine by therapy localizing to one acupuncture point. Dr. Belli also has a whole protocol of what therapy localization to K27 means in terms of central nervous system function. I'm just throwing this out there for your intellectual curiosity, is like you need to at least evaluate this when you find this cochlear nerve problem. It could be something more. It could be a third lumbar problem. Why? That's where the kidney associated point is, just saying. So they might have to get L3 adjusted, right? Then you might have to adjust the Lovett brother to that, right? I'm thinking AK. Does this make sense or am I losing you? Can we have like at least wave or something? I want to know. It's blinding up here. It's hard to see. Okay, thank you. Well, see, I'm missing Wally. It's like I'd be hopefully getting a nod for Wally about that. The next thing we need to figure out is, okay, could it be a cranial fault? And the answer is, well, heck yes, and how can we do that? Well, you could try and therapy localize, but there's a lot of bones around the ear, and that means a lot of therapy localization. I'm typically going to use just a shock absorber around the ear. And then retest all my parameters. Let's see, does that make any change? Now you're going to have to go deal with an osseous component. Is it a dural problem? Is it dural torque? Is it a cranial fault? Is it a TMJ problem? You could do that. How could you do that? I would do a normal TMJ evaluation, have the patient just tap their teeth together a couple times wherever they're touching. Now I would shock absorb, sorry, too many steps, teeth just touching, redo the tuning fork test. Does that make any change? Does that normalize my inhibition facilitation cycles? If it does not, then what I'm going to have them do is open and close their jaw wide a few times, then bite down hard, keep biting hard, do the tuning fork test. Does that now cause normal inhibition facilitation? Am I going too fast or does this make sense? Right? That's thinking AK for me. And then of course, you open and close a few times, stay open wide, redo the test. Then you know, okay, the cochlear nerve malfunction has got to do with the TMJ, right? It's not hard. You just got to system redundancy, and then you just have to follow your steps. Okay, my first step is normal inhibition wasn't there. The next thing I do, if it is involved, should cause inhibition. So now I can add one more step to that, which means no inhibition, inhibition, no inhibition. Does this make sense? You got to keep track of the questions and input you're putting into the ventral horn. Aha, it comes back to that, right? That's all we're doing. We're keeping track of the order we put stimuli into the ventral horn. And we can measure the results of that. Pretty cool, right? And then the last thing we need to do is, there is a system of acupuncture that a German medical doctor named Reinhold Voll figured out. And the short of the long story is, he said the Chinese people are brilliant, but they're stupid. How come there's 2 meridians on this finger, 2 meridians on this finger, but only 1 on these 3? And how come there's 2 meridians on the 4th toe, 2 meridians on the 5th toe, but the ones in between only have 1 meridian? They did this wrong. And so he set out to figure there's got to be 2 meridians on each finger, or these 2 should only have 1. And he figured that out. And that was kind of a parallel birth of electroacupuncture, or what's called electrodermal screening. He figured out by doing blood tests and electrodermal screening and a bunch of other tests that every acupuncture point has either a physiological function or an anatomical location that it's related to. So yes, he says there are white blood cells for cortisol. There's white blood cells for the anterior pituitary, for the posterior pituitary, for red blood cells, for white blood cells, for eosinophils, for basophils, for neutrophils, he says all that stuff. Here's where the EAV point for cranial nerve 8 cochlear branches, right there. So if you're seeing us treat patients, they could have a needle in here, they could have a laser beam going here, and I could be doing a cranial fault all at the same time. Right? Multi-dimensional therapy. The way you can figure it out, you can just use therapy localization, or you could just tap the acupuncture point a couple times, then do your tuning fork testing protocol. Does that make sense? So these are all the factors that could influence the cochlear branch of CN8. Any questions so far? Okay, so now here's that patient I was talking about. This is called idiopathic sudden sensory neural hearing loss. And so here's what happens with sudden sensory neural hearing loss. It can be a coronary artery problem after bypass surgery, a vestibular impairment, cochlear impairment, metabolic syndrome, TMJ problems, a virus. Someone was asking me about post-COVID hearing problems. Yeah, absolutely. Or some metabolic disease, or it could be psychogenic disorder. And that's all in the literature. From the disease standpoint, it could be tumor, it could be syphilitic labyrinthitis. I haven't seen one of those ever, so I don't worry about that one too much. Encephalitis, autoimmune hearing loss, ototoxic exposure, Meniere's disease, Cogan's disease, all those are possibilities. Well, that wasn't this 12-year-old girl. So now therapies that are in the literature, there's some osteopathic reference to cranial therapy, there's inner ear regeneration therapy, there's laser therapy, traditional Chinese medicine, steroid drugs is the first thing of choice. That's the first thing the pediatrician put the child on was steroids. That didn't work, then they said, okay, we better go get a hearing test. We'll talk about that hearing test. But in the literature, there's a lot of literature now showing that hyperbaric oxygen therapy is appropriate for this specific condition. Well, we happen to have one of those things in our clinic, and that's why the patient showed up at our clinic. They said, we've been reading in the literature, and we just found out that hyperbaric oxygen helps like sudden hearing loss like our child has. Do you think that might help us, Dr. Chip and Dr. Mladenoff? And we said, high probability. That's how they ended up at our place. So here is what a normal hearing test would look like, okay? This was her, let me see if I remember which one it is, or it says on there. Okay, I think that's her left ear. Right, so all the blue dots are in the normal. That's on 8/18/2021. Okay, there's what that's the right ear. The blue dots are the right ear, red dots are the left ear. And you can see there's a dramatic difference between her range of hearing in the two sides. So we examined her, and then Dr. Chip, my son, started a treatment protocol with them. And they did some acupuncture, they did some cold laser therapy, and then they did some cranial therapy and some adjusting, using the protocols that we talked about. How do you find these problems? Here's her test about 5 weeks later. So you notice the dramatic increase, right? The dramatic increase in the low frequency sound. That's why you got to use a low frequency tuning fork. She didn't get very much movement in these two frequency levels here, but she got change in every other frequency. And that's just in 18 so that's like not even a month. No, just over a month. That's pretty amazing. That's what we have the capability of doing. And yes, Lawrence, we need to publish this case study. So I need to get with you how we can do that. That's what AK will do for our patients. So to review, we're going to start with an independent indicator muscle related to the brain or ear. I'm going to suggest supraspinatus for the first group of tests. We're going to check a tuning fork, and we're going to check it in 6 different positions around the head. Then you're going to check the opposite side. Then you're going to use the other tuning fork. So start with the low frequency tuning fork first, then go to the high tuning fork frequency and see what changes there. You should get no inhibition with this testing. The second test is isolating where the sound comes from by the auditory reflex. So you have to pre-test neck rotators, flexors, extensors. I'm going to suggest use a low frequency tuning fork if you have tuning forks. If not, it has to be some loud sound. Do it on the ear and then check, okay, are the contralateral muscles inhibiting properly? You should get normal inhibition. If there is not regular normal inhibition, then you need to figure out how to fix that. I need to just go back a little bit here to the fixing part. Okay, there we go. So then you go to the fixing part. You could have just the tuning fork in a position around the head to check for the stereophonic perception of sound, or you could have the auditory reflex locating the location or origin of the sound, abnormal inhibition, or you could have a combination of the two. Okay, so any questions about the protocol? Pretty simple, right? It's like, yeah. Okay, so now I'd like to demonstrate this. Is Ken Parker in the room? There he is. Ken, come on up. See. I said I wasn't going to use him, but now that I thought about it, I forgot I had those slides in there about the idiopathic sudden sensory neural hearing loss and have it be after a viral infection. So if you can, just pick up the mic and, will these work? Can we turn on the mic so he can just give us a case history? Which one do you want him to use? There you go, just talk into the mic.
Case history is post-COVID tinnitus. Never had any tinnitus at all. In January of 2020, I got COVID before it was cool to have it, before we knew what it was. And then a couple months later, started getting ringing in the ears. And I've been battling off and on with it ever since.
Okay, so how do you think AK? The long part of this is if he has, I'm going to cut to the chase here. Sorry, you can just have a seat right here. The long part of this is if he has an acetyl-CoA problem of producing acetyl-CoA, it's going to be affected by the vagus nerve. And so we can do 2 tests to figure this out. We need to determine, I learned this from my good friend, Dr. Chris Astle-Smith. If you're online, Chris, good day, mate. And that is, you need to determine, is it a muscarinic receptor or a nicotinic receptor? And the simple way you do this is if we could just have you laying on your back for me and slip off your glasses. So we can tell one receptor by, we're going to check a gracilis muscle. So just turn your leg in a bit. Okay, knee straight, head down. Okay, squeeze your right leg to the left. And all you're going to do is you're going to shine a light in the ipsilateral nasal eye field, which means you have to come from the lateral aspect of the eye. So we're going to just do that real quick, just like that. Squeeze right leg to the left. Okay, we're going to do it the other way. I know I should be on the other side. This is not accurate muscle testing, David. Please forgive me, but you don't like the looks of my backside. So this is for stage presence and camera only. Come on, that was funny. Okay, pull towards me. Okay, and now we're going to just check this eye. So again, the reason why we're doing this is to determine, okay, is there a possible acetyl-CoA problem before we do any of the cochlear nerve stuff? no change there. So the next one for the muscarinic receptors, I believe, we need to see, okay, can he hold a muscle contraction for 15 seconds? So all we're going to do is we're going to just check the rectus femoris. Okay, just hold right here, just relax. I'm going to just check for autogenic inhibition. Hold. Okay, so it's functioning normally. Now we're going to just have him see if he can hold a sustained contraction for 15 seconds. Okay, I'll count for you. Hold for 1, 2, 3, 4, 5, 6, 7, 9, 10, 11, 12, 13. Okay, so that we're not getting any inhibition there. So the probability of it being an acetyl-CoA situation, not likely. Okay, one thing we did not add into the protocol. I'm surprised nobody asked the question. Well, couldn't you, what about just Sheldon? Dr. Sheldon Deal has a protocol where you just grab the whole ear and you squeeze the ear and challenge it and let go. I didn't include that in the protocol, and I'm just like thinking about that now. Why didn't I put that in there? So we could do that. So let's just, is it one ear or both ears?
Seems to be more right than left.
More right than left. Okay, so let's just, I'm going to just squeeze, let's use your arm here. Just give me a measure there. Okay, I'm going to just squeeze, hold there. Okay, well, I'm going to just check autogenic inhibition to make sure. Hold. Okay, muscles functioning properly, that didn't do anything. Okay, so if you could just sit and face everybody for me. Okay, so now we're going to just use the tuning forks. So we're going to, let me just go back. Okay, so we're going to do this protocol first. So he says it's mostly the right ear. Let's start with the right ear. Now, have you done any white noise treatment or any of those kind of things to try and find a counterbalance to it? Okay, so let's just have you hold right here. Don't let me push to there. I'm going to just challenge, hold. Okay, push up again. All right, so we've got a good indicator muscle, right? So if you were a fly on my wall, you'd see me do this almost every time with every patient. Why? You need to know you're measuring what you're measuring. Don't be sloppy. It's like a stethoscope. How accurate is a stethoscope? And I always like Dr. Mark Force. He uses this all the time when he's lecturing. He puts up a picture of a stethoscope. He says, how accurate is this? And the answer is, only between the ears do we know how accurate that stethoscope is going to be. So whatever's between the two earpieces. Right? So the same thing with your muscle testing. Be accurate in everything you do. So we're going to take the 256. I'm going to just get him ready. So you have to, it's like learning a new athletic skill. Otherwise, you're going to fumble all over the place. So you're going to have to test, hold the tuning fork in your left hand while you test the right arm, and then the opposite to the other side. Okay, so here we go. Okay, hold here, hold here. And I like to hit it about every 2 times. Okay, so we don't get any change with that. Let's try it on the other side. Okay, don't let me push to here. Hold. Okay, relax that. Okay. I like to do them diagonally opposite, like 180 degrees to each other. We're not finding anything there. Next, we do the same thing with a 512 tuning fork. Okay, so now you bang this against your knee's going to get sore. It doesn't make too much noise. You need something firmer to hit the smaller tuning fork against. Yeah, okay, we're going to use my knee. Oh, we got something there. Okay, so I'm going to go back and do 2 of them. The one in the back of the head. Okay, so we leave that there long enough, we get inhibition there. And the same thing in the front of the head. So just these 2 positions with the 512 fork gave us something. Okay, so now our time's good, so I'm going to go and do the second protocol before we figure out what we should do. Okay, so now in this protocol, it was these 2 positions that we found inhibition. So which tests should we do? Flexors and extensors, right? So just hold here. This is for my wife. Dr. Goodhart always said to test proper neck muscles, you use the Detroit position. My wife's from Detroit. We're now calling this the Chicago position because Chicago has more murders than Detroit. So it's now the Chicago position to test neck flexors. Come on, that was funny. Hold here. Okay, just relax. I'm going to check for autogenic inhibition. Hold here. Okay, so that's working good. Stay there. Keep eyes open. Okay, and look straight ahead, neutral. We're going to do the same thing here. Push backwards. Okay, so we have normal inhibition patterns there. All right, so now to do the test, I'm going to just leave his arms down. So we're going to use let's just do it anyway. We're going to do the 128 fork first. So if the sound is coming from the back, what should happen to the neck flexors? Should be inhibited. So I'm going to test the ones that should be inhibited first, because if the sound is not loud enough or long enough, and you check the ones that should be hyper-facilitated first, you might miss the inhibited ones with your timing of doing the test. Does that make sense? Okay, so we're going to just do that. Okay, head forward, hold here. We don't get any inhibition with that. And let's do it the other way. I'm going to do it just in neutral first. Okay, hold here, push back. Okay, and we don't get inhibition that way either. So both flexion and extension are affected in this pattern. Oh, sorry, we don't have the slide up there. And then only anterior and posterior for the 512. So the 128 worked for locating the sound, so that we didn't get normal inhibition. The 512 fork produced abnormal inhibition. Does that make sense? So now we're going to go through, if we could just have we could go to the slides for a second so I can put this up. So here's the steps that we're going to go through to determine causal and what needs to be done. Well, we've kind of figured out the acetyl-CoA factor with that pre-testing we did with the nicotinic and muscarinic receptor testing stuff, right? So we can put that one to the side. So next we can go to the kidney moo point. So I'm going to do the first test first. I want you to just touch. No, let's do this way. We're going to run into problems here. You have to think about this. Okay, if I put the tuning fork here and test this supraspinatus, how do I touch the right kidney alarm point? And the answer is, well, he can't reach there, so now do I use a different muscle so he can touch this way? It's like, okay, you now have to execute thinking AK. So you have a way around this. Remember, system redundancy, one of the ways is hit the tuning fork, I can tap kidney alarm point a couple of times and then test. Okay, there could be other ways, but let's just do that one for expediency's sake. Okay. Remember, the order of sensory input into the ventral horn determines what answer you're going to get from the question of the motor neuron. Right? Don't ever lose sight of that. Okay, relax for a second. So we're going to do tuning fork first. I'm going to tap kidney alarm point, then I'm going to test. Okay? Okay. Okay, and then hold here. Well, that causes facilitation, meaning now it's normalized. Okay, so kidney meridian. So now I'm thinking AK. Do you have low back problems? Some. Is this psoas muscle always upset?
Doesn't seem to be.
Doesn't seem to be. Okay, see what I'm thinking? I'm thinking kidney energy patterns now. I'm thinking psoas. I'm thinking low back, right? Then I could think Wu Jing kinesiology, and that is Keiko Matsumoto came up with a protocol to figure out adrenal program problems if you palpate K2, K7, K10, and K27, and if they're tender, then you have an adrenal problem. Well, wait a minute, the tip of the 12th rib could be a positive Rogoff sign. So is that tender when I push right there? Okay, so I've heard it two ways. Some people say that, well, Rogoff sign is actually tenderness at the tip of the 12th rib at the rib thoracic spine junction. So any tenderness over here, no tenderness there, okay? So I'm just doing this to illustrate what I would think as I'm doing this test. Does that make sense? So we know kidney alarm point normalizes this response. Next, just touch right here. So we're going to go to K27. I'm just having him holding his hands like that. So he's holding like this. Okay, and let's, okay, and hold here. Okay, that does not change it. I'm going to just double check because I'm new at this stuff. Okay, that time it did. Okay, hold on a second. Take your hand off. Okay, I'm going to just tap those two spots. Okay, hold here. And I hit the tuning fork a little louder, and that doesn't change the abnormal inhibition. Our next step, okay, we can therapy localize bones around the head, or we can just do a shock absorber. Okay, hold. That didn't change it. Wait a minute. This is a COVID viral infection. What's the fastest way you could get to this? The yuan point, or the triple heater meridian, is the greatest organ connection between the triple heater meridian and the thymus gland. What? That's TCM, traditional Chinese medicine. So you could go, quantum leap, you could just tap triple heater 4 a couple times, hit your tuning fork, hold, and all of a sudden that normalizes the response. I purposely left that one in the bag as my big close, right? Because it was immune system mediated, it was a viral infection. Okay, and our last one, just touch right here with your left hand, please. So that's the EAV, the VOL acupuncture point for the cochlear branch, cranial nerve 8, hold. Okay, and that doesn't change it. Just to humor you, Wally, okay, let's just go to the thymus VRP. Hold. And that also normalizes it too. No, that didn't. Wait a minute, backwards. I'm backwards. Hold. No, that didn't change it. So just the triple heater meridian, not the thymus gland itself. Well, wait a minute. Well, I don't know if the spleen is also. So now you should be going to the spleen. I'm thinking AK now, right? Should go to the spleen. Why? That's related to your immune system through the vagus nerve. Well, you could go therapy localize right to the vagus nerve, which is about a ½ inch below the bifurcation of the sternocleidomastoid. Is this making sense? Why I'm doing all this stuff? Could the vagus nerve have been affected by him getting that viral infection? Heck yeah. Okay, I'm going to use my other knee. My left knee's killing me. Okay, hold here. Well, wait a minute. That normalizes it too. So what? Thank you. So what can we conclude from this? The tinnitus on this side, the cochlear nerve is not working properly. We know it's got something to do with kidney meridian, got something to do with the vagus nerve, and something to do with the triple heater meridian and part of the immune system. And now the magic of AK begins. Now you need to figure out all that stuff of what to do about it. Does that make sense? So a simple concept, thank you. A simple concept of how you can figure that stuff out is pretty powerful. But if you don't understand the neurology, if you don't understand the ventral horn concept, you're not going to get it. That's also why we need to speak neurological speak when we talk to other practitioners and not do what Dr. Belli calls AK speak or twin speak. Are there any twins here? No twins? We usually have at least one twin in this group. Well, twins kind of have their own language, right? They talk to each other. Nobody knows what they're saying, but they know exactly what they're saying. That's what we're talking about. We can talk about stuff in AK that nobody has a clue. No chiropractors know what we're talking about. What's a subluxation? What's a fixation? What's a lesion? Are those three things the same thing? That's what we're talking about. So we need to talk in terms of neurophysiology. Questions. That's my presentation. Simple protocol. But just two different applications of examining it. One is the stereophonic transfer of sound, so you got to check the sound in 5 positions against the supraspinatus. And then the other one is the auditory reflex. Where is your head going to turn to locate the sound where it's coming from? Should get inhibition of the opposite muscles, hyperfacilitation of the ipsilateral muscles trying to locate the sound. Then you can determine using your AK tools, what you need to do to address this. Questions? Yes, sir. Say again? Absolutely. He says, could you, if you have a tuning fork app on your phone, work? Absolutely, and your knee won't hurt as much either. So if you see me limping around in the next couple hours, it's like it's right there, especially the 512 tuning fork. That hurt like heck. But you were worth it. Other question? Yes? No. Stomach 1 is like literally, if you go to the rim of the orbit, you'll feel a little notch there, the inferior orbital notch. That's where stomach 1 is. So you're about half soon inferior to that in the center of the eyeball. Other questions? Yes, sir.
Did you end up putting your case study on the barometric machine?
Has she gone for follow-up testing after more additional treatment? And the answer is we did, I think she did a month's worth of hyperbaric oxygen and then some additional cranial therapy, chiropractic, AK adjusting stuff. And I don't have the results of that. I don't remember if she went back for additional follow-up. We'll have to text Dr. Chip. So Dr. Chip, if you're online, if you got results of that, fire them off to me and we can let everybody know tomorrow. Last call for questions. Thank you very much. Howie, I left you 1 minute.